Okay, let's talk about some of the amazing achievements that can be made and what parents have to say about it. So, we're saving the best bites for last here. I love feeding. It is so effective, so fast, and rewarding. There's so much potential and hope for families, as they have said, have tried everything. The success rate is pretty much 100 unless they can't swallow safely or they have medical complications. And major progress is often made in the first day or even the first session in less than 10 minutes. And they get so many rippling positive benefits from it. So this treatment comes from a hospital where patients come from all over the world for a 2-month admission when they learn to eat and drink. There are only a handful of places like this in the United States, and they originate from people trained at this one. So being able to learn here changed my entire life. The motto they have is unlocking potential, and they accomplish miracles. So it's not about what the child can't do or any excuses there. It's about doing whatever it takes above and beyond for them to achieve the best that they can. So this quote here, Kennedy Krieger is a very special place, a place where hope is alive and well, futures are found, lives are transformed, dreams are fulfilled, and possibilities are pursued every single day. And that might sound like fluff, but having been there, it's actually true, and it still speaks to me. I was over 30 years old. Baltimore, going here was my first plane ride away from home. I only knew how to what Cajun food was, couldn't read a menu, had never been in the city, so there was lots of firsts for me. This was my first habit journey outside the Shire and was very life-changing. So what we're showing here is translating this into homes in Australia. I never thought we'd be doing this, but I got a big suitcase of supplies from the States, and we travel all over. We rent Airbnbs next to the family's homes for weeks at a time. It's been quite an experience and a wild ride. We've been in remote areas, had to rent a room in somebody's house and share. I'll be coming home with food all up in my hair, and they're like, what do you do for work again? So as much as I miss having the resources at the hospital, it's way more special with the families and more flexible and fun. The food, of course, is light years better than what you get in the hospital. And we're able to party it up way more without all the hospital regulations. So we even had a parent let us use sparklers indoors. So I do all this direct feeding intensive work myself, and I've had the same assistant for nearly 10 years now, thankfully, and that's Nick. There's plenty of cameo photos of him in this talk. He is my ride or die, my partner. So on competence, because this is a super risky and serious area, it's like the difference in training you would get from a GP versus a specialist like a surgeon. So Kennedy Krieger and Johns Hopkins, it's a well-oiled training machine for this. And they actually did a knighting ceremony for us with a golden Nook brush for our graduation. So this is 26 children in Australia at this time, and we have a replication that we've published with 32 kids, and in total we've helped over 50 kids in Australia now. So the word consecutive means it's all the cases, and this is to account for the publication bias, or what they call the file drawer problem, where stuff that doesn't work doesn't get published. So all these cases have experimental control using single case experimental design graphs. The data has reliability and integrity metrics on it, and they all include parent training and getting the parent's perspective on the treatment. So the treatment was brief, and I mean only weeks, and the average duration of treatment was 11 days. So I'm emphasizing that most of what you're about to see was all achieved in only 2 weeks. There was a wide range of cultures. Many had English as a second language. The average age was 6, and most had developmental disabilities and a long history of failed previous treatments. So this was quite an experience getting this into a pediatric journal. I was trying to publish outside the box. They actually sent me to a language editor, and they toned it way down and made it really easy to read. All right, let's talk about what real success is. It's not dancing in spaghetti noodles like Patch Adams or bathing in them or making snow angels. No real nutrition or practice is to be had from cozying up to and kissing Brussels sprouts to painting with chocolate pudding. This does not count as making progress, so let's continue therapy. That's never going to work. This is a quote that we got from a report from an actual case. And don't trust the Cookie Monster. He just pretends to eat, but he never swallows anything. He's spitting it out. He ain't chewing enough. Food has to actually be eaten for it to be nutritious and healthy. Your body don't care if you're kissing chocolate cake or broccoli. So teaching kids to spit out or hold food in their mouth on their tongues without chewing or swallowing is not a socially valid goal or treatment target. It's actually an inappropriate mealtime behavior that we target to decrease. So this poses safety risks, and it's not what typical eaters are supposed to do. So, and despite what people think and claim, there's actually no data saying that parents or kids like this stuff. And parents actually tell us the opposite. They are totally sick of it. There's lots of wasted time, money, and effort in the kids' critical developmental years doing this mess. Meanwhile, they don't have the nutrition and hydration for their growing brains. They're missing out on skills and socialization. They're not learning or getting exposure and practice with meals or food. And it's impacting all the other areas of their lives. The rest of the time they spend outside of your therapy session, when the parents are left alone, the parent and the kid still has to go through all this hard medical stuff that they have due to their diet, like doing suppositories or fighting to get meds in. And it's when they're older, it's harder to get treatment, if at all. So people spend years kissing and playing with food that rarely leads to actual eating. It feels really silly to have to say that the main outcome of feeding therapy should be actually eating. And don't let kids play with their food or spit it. And parents say the same thing, and they're right. So we do mouth clean and swallowing checks and observational data collection. Uh, we love these plots. It's finally finding a way to make individual and group data and math all be friends with each other. So here you can see each kid's individual results instead of being lumped into the group, and you can see how big the change was for each kid. So this is percentage of bites they ate on the vertical axis, and higher is better. We want this to increase. Each case is on the horizontal axis, so each dot point is a kid. Initial baseline is the open circles all at the bottom when they barely ate anything, and initial treatment is cross circles where they ate almost everything, 100%. So the three exceptions are because they had a different design, but they did meet 100% of their particular criterion in their full plate meals at the end. This middle graph is comparing the initial baseline to the reversal where you take away the treatment, which is the squares. So this shows that they won't eat without the treatment, and it's replication for experimental control. So the treatment is the reason for the change, not time, history, or some other factor we're not measuring. And again, this is not just case studies or pre-post designs. This is peer-reviewed quality research with experimental control. Here you can see there's no overlapping points, and the kids reached 100% consumption on the first day of treatment in an average of less than an hour. Initial treatment and final treatment are exactly the same, so we didn't do a graph of that. This is a quick summary of the results, but think of the progress monitoring table we talked about in the first part of this talk. This is what needs to be achieved. So let's go through the rest of the results now. This is variety, so eat-in foods from the real food groups. On the vertical axis is the total number of foods with baseline on the horizontal axis. So we want this one to increase too. So children went from an average of 6 foods to 92 foods, and that cross in bold is the average for the group. So nowadays, parents are getting competitive, and we typically do break for 200 foods now, and we give them little cutie award certificates. The effect size was huge at 4, and that diagonal line means there was no change. So any dots that would have happened below the line would have meant they got worse. So none of these kids are anywhere close to that line of no change or getting worse, and all the kids got better. Grindage. So this shows how things can escalate quickly. The record total is 224 foods, and that's Como, who we'll talk about later in the talk. And we're not using any real names here. This is a pseudonym from the publications. So you'll see him later when we talk about lived experiences from the parent's perspective. And all this was in less than 18 days when we were also working with his sister. The light gray path is new foods that he ate outside of session without any kind of protocol on his own choice. And that goes up over time because of repeated exposure. They eat more foods on their own that they get used to and start to like. Vegetables are typically the lowest group before treatment. Baseline is like a straight line at 0 here, and only one kid in this whole entire sample ate one vegetable. Once a kid gets into a new routine, except for restrictions due to allergy or texture based on their chewing ability, you can increase variety pretty quickly, oftentimes, but in small amounts at first. This is how long it takes them to take the bite in seconds. We want this to decrease and be around 10 seconds. It depends on the bite size, the utensils, and the feeding skills for each person, though. In baseline, they might hit a time cap of 10 minutes without accepting any bites. And then in treatment, you can see they take their bites really quickly by themselves. Uh, this is how fast they swallow the bite. And the target would be around like 30 to 45 seconds or the goal. But it varies depending on the bite size, texture, and their chewing abilities. So it's got to be just right, like Goldilocks. You don't want them swallowing too fast or too slow either. Either one is risky and not ideal. This is head turning, covering the mouth, and batting at the feeder or the utensils per minute. And you can see it was really low in treatment. All the cases are hanging out at the bottom. So this is inappropriate mealtime behavior. And this is my feeding friends from the hospital, and we're demonstrating all 3 moves. And I did not get permission to use this photo. So spitting out food expels. This was really low in treatment. And last is crying and complaining about the meal, which was again very low in treatment. There's only one outlier, but in this full plate meals at the end of the program, it was low. We also do intensive follow-up remotely for 2 weeks immediately following the program. We watch every meal video they do, and the parents take data and plate pictures, and we write back and forth on a shared electronic spreadsheet. And the kids made 100% of their goals, and these gains maintained to an average of 2 years at follow-up. Okay, so this is where the Cookie Monster would get told on because we weigh everything in grams, including the spill that fell on the floor. So I really want to emphasize that the meals I'm showing here were actually 100% consumed. We do multi-method, reliable, peer-reviewed experimental data to prove that, and we never show plates that were just served and not eaten. Um, and I put a detailed disclaimer on my website detailing this. We do wild amounts of data, and I do go over this in longer workshops, the data part. But presentation is everything, so now on to plating. We start with really small cut up bites and just a few drops of the drinks with adaptive equipment, all individualized to each child. And once they're able, we get to a more natural meal, and we love getting these pictures of the plates. It's such salient evidence of their achievements. And looking at them, we have so many fond memories. This is the first article that was published with actual permanent product pictures, which was really exciting. And if we have time, we get to larger portion meals. And I love these. We got to learn how chapati and paratha bread were made by watching his mom here. So volume is actually, it can be one of the easier things for parents to increase on their own after the program. So often we're pushing variety and keeping the meals small unless they're trying to get off a tube or their growth is low. And here's a more recent collage. People will show you pictures of their kids and pets to ooh and ah over. But for us, these are our babies. We stare lovingly at them, get really happy. We love all the different plate designs. We got an Australian one with a koala and a kangaroo on it. People have all their shopping addictions. Mine is kids' feeding gear. So with that metal plate, the mom didn't want to use plastic. And how funny in a talk, somebody was like, that looks like a prison plate. And yeah, since I'm giving this for Australia, we have a joke too from the movie The Castle, and sometimes we'll take a good plate picture that we love, and we'll be like, "That's going straight to the pool room." So making these plates can be very creative, interesting, and fun. Using all the foods the family eats, many different cultural and ethnic foods, foods the kids can participate in their traditions and celebrations, and we love learning about all that. We get the school and the child care menus and practice those foods. And some families get a lot of Uber Eats, and some families have a lot of home cooked meals like grandma's specials. Another important goal is to get off of a feeding tube. Here's ALOI we talked about earlier. And the graph is just showing how we do this gradually, not cold turkey, and it doesn't require hunger. And it's very similar with preferred foods and drinks for kids without tubes. We help the parents to gradually do it rather than blindly giving them recommendations to try to do it on their own. Plus, there's no weight loss. He actually gained weight, and there's full nutritional variety, as you can see by his plate pictures. And you can see by the graph, his intake was consistent. There wasn't ups and downs. So there's a lot more publications in feeding that focus on solids versus liquids, and there's some publications on pill swallowing, but this is the first one on medication acceptance. This is a huge struggle for families holding the kid down, syringing it, they're vomiting, they're losing expensive critical doses, the meds are flying everywhere. This is a huge safety risk, and it's intertwined with all the other feeding problems and risks these kids have, like longer illness and recovery time, constipation, and seizures. And if the kids have a tube or a baby bottle and they get treatment for that, the parents then need a new method because that used to be the only way they could get the meds in. So ideally, the need for these medications would decrease after feeding treatment because they're eating and drinking better. But this practice still gives parents a format if they're prescribed antibiotics or cold medicine or pain relievers. And just to give you an example of the types of cases that we've seen, Jesse was 5. He had stopped drinking his formula. He had to have suppositories every other day and wouldn't drink any laxatives. He ate 0 real food group foods. He only ate 3 specific infant dissolvables at the first stage. He never learned how to chew regular texture food, never fed himself, and had never drank from a cup, and wasn't eating anything off utensils. Max, those were the big plates I just showed you with the chapati and the paratha. He was 8. He was still in a baby bottle and infant cereal. He had obesity. He did 0 toothbrushing and had decay from the bottle. This is another common issue with formula. And he had to have suppositories for pain relievers. He ate 0 fruit and vegetables and grazed on junk all day. And he only ate 2 real foods, and the parents finger fed those directly into his mouth. He also had severe problem behavior, biting himself and others, aggression, and self-injury. So I love this because instead of someone squirting it into their mouths, they can do it themselves and with a spoon or a medicine cup. And they can be independent without all those struggles and stress. And it's really quick, so it happens in seconds. And you know exactly how much got in, which is super important with medications. Plus, it's honest. You're not hiding and sneaking stuff. So we did solid treatment evaluations for food for these 2 boys at the same time, and the whole treatment evaluation for both only took 6 days. So they learned to take formula for calories, laxatives, and supplements with a variety of flavors, multiple forms, so thick and thin liquids, chewables, and gummies, and different delivery methods, so finger feeding using a spoon, a cup, a medicine spoon, and a medicine cup. And also very important is for them to learn how to drink water, drink from an open cup, a huge important skill, and from a variety of water bottles, which is a big thing in Australia in the schools. And dehydration can be even more dangerous than starvation. They can end up in the hospital. Plus, it causes all kind of problems with, bleeding, cracked lips, skin problems, and constipation. So, doing this, you do have to consider the dosage, bolus, and the volume and the consistency, along with the child's skills when you're trying to decide what utensils to use. And you need an interdisciplinary team recommendations, and the parents have to prepare and adjust the dosage. So, and you also have to keep it small so you don't exceed it, or you have to find some kind of mop thing that you can use to practice from a chemist, or some kind of cordial or vitamin they can have more of. Children can go from liquids and baby food to regular texture. There's less research on teaching chewing. It involves a lot of steps and can be really difficult and take a lot of time. Juno was a 5-year-old. He had no chewing history at all, not even baby puffs or rusk, and he only ate pureed baby food. The parents had done everything to get help, including an intensive interdisciplinary hospitalization and hunger provocation. Didn't work. He doesn't know how to chew at all. He learned to chew in just 3 weeks. This is a picture of food texture progression. Textures are super complicated. When we look at food, we see a million things to do with chewing and texture. The bite size, the shape, the skin, the juice, the stickiness, and you have to organize it and increase it perfectly for them, like Goldilocks, due to the safety risks. So it's very tricky. You don't want them too slow holding it in their mouth and packing, over chewing, and you don't want them doing it too fast either, early swallows when it's not chewed up yet. So Juno learned all the chewing steps. He learned to bite off, chew, lateralize, masticate, judge when it was ready to swallow. And this was a big feat. We had to teach it all specifically. He didn't know how to do it. His graduation meal was really special because it was a kid's meal from a popular fast food restaurant that his parents owned. And it was the first time he was ever able to eat the food. Also, the parents were so happy telling us that he ate a sandwich on the plane home. So 1 year after, they said he would generally eat anything put in front of him. And 3 years later, their ratings were all above 6 out of 7. They said they didn't need the protocol at all and that it was the best thing they had ever did. And they can't say thanks enough. And he can eat all foods. There's also way less publications on independent skills. So heaps of cool stuff has been done in feeding with fading, and that's making gradual changes based on what they already do. So those photos, you can see they're moving from a syringe to a spoon, from a syringe to a cup, and gradually making changes until you just have the spoon or the cup, and then moving from a spoon to a cup, where you eventually fade out the spoon and they're drinking from the cup. So, but there's nothing in the literature on these pouches. So these are kind of new in the last decade. People are publishing concerns with them. The kids are getting stuck on them. It's impacting their health and their socialization and meals and their skills. So Moreau was a 3-year-old. His only independent skill was this pouch. He did not even finger feed, and he vomited at the sight of anything new during just given choices in an assessment. So we did a multi-element comparison of apparatuses to transition to the spoon. So the top photo is an attachment you screw on. The second photo is a squeeze bottle spoon. And I want to add that rather than us trying to pick what we're going to do or guessing, we gave Moreau the choices of these things first, and then we did a direct assessment of his performance with all these options and decided based on the data and the results, all before we did any parent training or recommendations. So we ended up using a tape spoon to the pouch and did pouch to spoon fading. So we gradually increased the distance, moving the spoon forward till he was taking it off the spoon instead of the spout, and then we got rid of the pouch. So this is the only real picture we're using, and the parents did give her permission to use it. It's actually a snap from a real video, and he's not posing here, even though he looks like it. So he learned how to use chopsticks, and my mom doesn't even know how to use chopsticks, and I was over 30 years old before I learned, and I probably still ain't doing it right. So he was adorable with this. He would say the steps: open, close, fun, and he'd be smiling. It was really hard, tedious work. It took a lot of time, but he got to where he was a little expert with them. He even did vitamins with them. He did a slippery bald egg and a small little bean, so it was a real blast. We also got a lot of valuable cultural, social validity information and parent perspectives, lived experiences that we put in this publication, and I'll show you this at the end of the talk. So he learned 11 different independent skills, and he did all of this in 2 weeks, which was incredible. But like I said, a lot of hard work. So I have a whole talk on this, and a huge treat is that it has actual videos that the parents gave us permission, but only to use for live talks, not recordings. So it's such an amazing talk. You can see before and after videos and the progression of his learning with all these skills. So Plus, the best part is his mom's reaction when she first feeds him and sees him rocking all this. And then at the end, we did restaurants and parks and his birthday party. So we were really tickled to have just given this talk in all places of Japan. So we had to make up these chopstick steps with his mom and Google. This was new to me, and there was no research I knew of to consult. But actually, when I was writing up the publication, I found a few in Japanese, and this is a cool one where they use fading to fade the rings out to get them to regular chopsticks. And since then, we've done heaps of follow-up with him. We've done cafes. We prepared him to go to school, and parks, and we need to pull the videos to add to the presentation because he was doing a lot of stuff independently. Another neat aspect of feeding is the differences in cultures. It's like traveling. There's always something new and exciting to learn and see, like using bread as a utensils or knowing not to eat the banana leaf wrapper or the watermelon rind. For me in Australia, it's people using the knife and fork for everything, like they're doing food surgery. This is very advanced to me. My people don't do this except with steaks, and I'm vegetarian, so I had to learn too. So we did a follow up with a kid here, um, and when I was with him, he had a kids section plate and kids utensils. And when I saw him in follow up, he was doing all this with adult metal utensils and a breakable plate, and was teaching me. So we've been doing a lot of follow-ups recently, and we did video modeling and Play-Doh practice very briefly, and of course got to real food real quick in the meals. But heaps of other advanced skills we never really got to in the hospital. Had a lot of purees. Also, most parents have a goal of wanting them to sit and eat and participate in the meal without electronics like the iPad and the TV. They want them to finish the meal more independently and quicker without needing distractions, and want them to sit at the table and stay seated. Don't want to be chasing them all around the house to get them to eat and drink. And so there's so many mealtime skills to learn, like Moreau, self-feeding, using utensils, scooping the right bite size, sipping from a full cup, biting off portions of food instead of cut up bites, and using a fork. Yeah, there she goes. She got it. Go, girl. I want to adopt her. And double plates. So this is Tabo and Shay, and they were little brothers. Often parents realize during the program that the siblings aren't eating as good as the child that we were originally there to help. So it's one of our favorite things to do. It's like dueling piano or banjos. Each kid separately at first, and then bringing everybody together at the table to eat. It's a blast. And it's normally way easier and shorter because they're younger. So there's a huge, huge need for earlier treatment and a focus on prevention in feeding rather than older ages and reacting when it becomes even worse of a problem. So this wouldn't be allowed in the hospital with the hygiene rules, but I would hire this dad for not mixing up all them bowls. So having a family meal, all eating everything at the same time, is a reported dream goal that parents think can never happen, but it can. So except for dietary and texture restrictions or individual differences there, and it's often a lot easier and funner when we work with the siblings too, but if not, we can still help the parents come up with a plan for them to join in. We also do restaurant and cafe meals down with the kids menu. We have had servers coming up to us asking us if we want the kid menu, and we're like, nope, they're going to eat what we're eating. So we've gone to schools and hid behind plants to watch meals like Inspector Gadget. We typically only train the parents on the protocol because it's too important and risky to feed someone else's child. But we will give others like grandparents free access choice guidelines to follow. And we'll talk about these later with Como. Trying to reach more families with tubes recently, and I love how y'all pulled this quote from the 2022 program, talking about how it's such a special journey to go through this with the families. We love getting the updates after the program and hearing about them being able to go to camp for the first time overnight, videos of them eating their first birthday cake, or seeing pictures of what they ate on the plane going home, like Juno. We'll get pictures and videos of them eating barbecue chicken off the bone, using chopsticks at a restaurant, opening their own lunchbox at the park. We had 2 cases where total strangers come up to the parents at the pub and ask, how do you get your kid to eat steak and salad and not just hot chips? And that's the ultimate compliment after all the heart and soul that goes into this from somebody that didn't know. And I'm not the only one who was touched by this graphic y'all made. How special is this? I was at a conference and the keynote speaker saw our talk and added it to his opening address the next morning. Similarly, with this blend article, just talking about how with all the complexity and hard work that goes into it, it's so rewarding to finally see all the child's their first independent bite with a spoon. We have that on camera for Moreau. The first time you hear him a chewing noise and you're like, oh, they finally did it. And them experiencing so many foods for the first time, their first Vegemite. A first for us too was Moreau with learning how to use the chopsticks. And also, parents are telling us they're seeing so many benefits beyond eating, like blossoming into other areas. They're opening up. They have improved self-confidence. I thought that was so sweet. And all of that after being told that the child can't or wasn't ready. So treatment can have rippling effects. We didn't realize this until we were staying in closer touch personally in follow-up. So it's really exciting and new for us to learn about all this too from the parents. So of course their health improves, but another super common one is toothbrushing. Parents will be like, he lets me brush his teeth now. I don't know what happened. And we're like, wow, we didn't work on that, but I'll take it. Same with Como, who you'll see next. He had a desensitization program for months. He was going into the hairdresser every week, getting a little lopsided snip of a haircut. And the parents later told us, oh, he got a full haircut in one go now. And again, so many firsts, staying overnight with a family or friends or with a babysitter, having the strength to do sports, and all the reactions of the teachers and the therapists when they go back and they smash a healthy lunchbox and join in with their peers rather than hiding and crying during meal times. And all of this when they've only been away a few weeks. So hearing all this from parents, you realize how much getting feeding treatment can really open things up. Like they'll tell us even small little things like, oh, she used to refuse to walk on the bark section of the park or drink from a water fountain. And all the comments like we were talking about of the self-confidence and the blossoming. So change is really hard, but the more difficult and uncomfortable things we do often give us the biggest rewards and payoff and joy. So parents often say parent feeding is the hardest thing for them and their kid. We've seen some kids, and you'd never guess they had any problems, but when it comes to a meal, they were completely different in a meal. So, like we were talking about being a ride or die for parents during training, we also give them lots of help and resources like acceptance and commitment therapy stuff, and more like a real clinical psychologist here. So some good examples of this kind of concept we're talking about for kids would be learning to swim in Australia, or for anyone learning to read. Flying up on a plane opens you up to the world. I did this as a grown up. My first flight was to internship in Baltimore. And also things like a really common one would be public speaking. So I never did this before Australia. And there's many sayings about this that I've written out here. The Cajuns have a simple, funny one, and it's don't drop the potato. So time is of the essence in feeding. The whole family is struggling, and most children are literally starving before the treatment. Their brains and bodies ain't getting what they need. Parents are already uber stressed dealing with this every day, every meal. And so in this asking parents their preferences, they want the treatment to work quickly versus trying to minimize any crying. They want timely, effective services. Most have already had the opposite for years, and they can't wait for real treatment and results. So not only is the child physically suffering, having to go through all these medical interventions that come with feeding problems, but they're also dealing with the stress of this every day. Every time they're served a meal or they hit with a new context, or a new therapist trying to get them to eat or drink. So This review paper has a detailed full table of goals for progress monitoring and the maximum time it should take to achieve them. So I don't know how you can keep doing treatment for years without real results, but we see it all the time. And unfortunately, it's the norm. This helps to comprehensively see what needs to be addressed and what real success is. Not getting hot chips from a different fast food joint or a couple of foods that aren't green vegetables. If it's not real big success, then the treatment's not right. You're wasting critical money and time and effort, and they need to be referred on. These are the standard goals. And remember, we're talking about novel, nutritious food from the food groups, not junk or snacks. And actual consumption, they have to swallow the bite or drink. So we want them to take and swallow their bites quickly, without refusal, spitting out, packing, which is holding food in your mouth without chewing or swallowing it, or crying or complaining about the meal. And this should happen right away. But on the training piece, you're supposed to work yourself out of a job so that they don't need you or therapy anymore. This ain't Freud and psychoanalysis. So, like I said in the intro, I know I don't come off like a ClinPsyc, but you can see these goals. They're not fluff, they're or psychobabble. This is short-term, observable, measurable, real goals with numbers and criteria, like we saw in all the graphs. So these are some other goals that you want to achieve in less than 3 months. So the food group variety, have a variety of foods from each food group separately. You want them to be able to self-feed and use utensils. Want them to be able to drink from an open cup and drink water, definitely, and if applicable, formula. And like we were talking about, take their medications independently. Now, some of these goals might be longer and need to be individualized, because in these ones, you have to consider the child's chewing skills, how much volume they can tolerate, their growth, and their medical and health status, and if they have any food allergies or swallowing difficulties. So, texture is in this category. This is some texture goals. And then volume, these are volume goals, taking their stuff, taking their liquids and solids orally instead of in a baby, and their medications instead of a baby bottle or a tube. And then independence, so scooping and having full plate meals, biting off, full cup sipping, using regular equipment, not using a baby bottle, and maybe getting to a fork. And then simplifying the protocol to where they can do it by themselves and not needing so much help. And then generalization. So this is making it, with other people in other settings, and just a variety of utensils and bowls and water bottles. And then really simplifying the meal procedures as simple as they can be and as typical. So we also do intensive follow-up for 2 weeks remotely, watch every meal and write back and forth on the shared electronic data sheet. And like we talked about earlier in the first part of this talk, some of the kind of misconceptions, like with toilet training, we're not going to get a prize for each bite for life going into old age. So simplifying earnings and making it more natural eating. We've helped over 50 children in Australia now, and we'd love to replicate this CCCS group publication again to add to the in-home intensive feeding literature and focus on tube dependence, medication, and cup drinking. And prevention. I love Australian culture. It's so refreshing and good for me as an overcaffeinated type A American, but this is not a no worries, mate, she'll be all right type of problem. Age is a ginormous problem with children not getting the right treatment early enough. We've heard so many heartbreaking stories from the parents of their journeys and trying to get real help, struggling unnecessarily for years when there's an effective and quick treatment that works so well, and that's already been out there for 50 years with heaps of research evidence behind it. And finally, we'd love to do more long-term follow-up to see what our kids are eating as teenagers and adults. This treatment requires high expertise and training that's only available in a handful of hospitals in the United States. It took me 15 years training total to learn how to do this, and I'd say it was only after being in that hospital program for 4 years that I felt comfortable and confident. And we wouldn't be able to do what we're doing in Australia had I not stayed as long as I did, which is over 5 years. Then, when I got here, I had to learn over the last 11 years how to transfer this to homes. So it's not just us saying this. You'll find this competency point highly emphasized all over the feeding literature. You can't learn this at a workshop or an online course, which is sadly why pseudoscience and bonk treatments are the norm. This treatment requires appropriate intensity for lots of reasons. An hour a week is not appropriate. We eat 5 times a day. Also, judging case severity is super hard, and sometimes you don't really know until you're in treatment. So you have to have the feeding expertise to be able to judge case severity, and some kids do need an expert interdisciplinary and hospital setting. I still refer kids there. So this is incredibly important outside of controlled settings like us, or if you're providing less parent support, asking them to do stuff by themselves. We provide a very high level of support. We don't tell them to do anything without us at first. So even antecedent strategies like feeding can be dangerous without a tube as a backup means, or if the kid shuts down on the one thing they eat or drink after you were messing with it. So finally, another huge issue that will really help feeding treatment overall is if kids got this earlier the proper way. Imagine trying to feed a 1.5-year-old, trying to teach them feeding in a high chair versus, and that's when the problems have just started, versus trying to teach a 10 or 15-year-old. Okay, on to COMO and social validity. So that's lived experiences and caregiver perspectives. And there's 3 parts to that definition. So number 1, the social significance of the goals. Are the specific behavioral goals really what society or the client wants? Number 2, the social appropriateness of the procedures. Does the ends justify the means? Do the participants, caregivers, and other consumers consider the treatment procedures acceptable? And then third and last is the social importance of the effects. Are the consumers satisfied with the results? All the results, including any unpredicted ones. So I found an email with me and Dr. Tessa Taylor from New Zealand from 2016, so nearly 10 years ago. We started doing some research in this area. It's a really hot topic and much needed because in the past there was surprisingly not enough data on it behind all the talk or the talk from people who should know, like psychologists. So there was lots of gaps to fill in terms of the data and the measurement of it. And this is a case example that I'm going to show y'all, COMO, not using real names. And recent advancements we've done in putting this work into action. So there's lots of utility and implications for practitioners in this one. The goal here is to add to the objective numerical data all the stuff we just went over. This more subjective information is meant to complement rather than replace the quantitative controlled scientific data. So this is just a bullet point review of the findings in this area we went over in the first part of the talk. So caregivers rate empirically supported treatment highly positively. This is a summary of over 400 cases with no negative side effects. So often the meals that they're dealing with every day and the many impacts of the feeding problems they're dealing with every day are way worse than the treatment. And that empirically supported treatment reduces their stress, has positive impacts on the child's emotional and behavioral functioning, and can increase child happiness and quality of life. So unfortunately, much of the discussion in this area doesn't match the real data and not coming from the right discipline or competent experts in this area, which would be, include the real parents who have gotten proper treatment and support, plus ClinPsycs that are specializing in this area. So parents who actually get proper empirically supported treatment, meaning intensive services with high training and support, they rate it really highly and positively. So this is 32 kids of ours, and you can see the ratings all at the top, and the average rating was near 5 out of 5. Historically, the focus has been more narrowly on the exposure procedures and not the actual data available in literature firsthand from the real parents, or like we did on the intro slide, the broader definition of social validity, which includes all three: the goals, the processes, and the outcomes. So we need to consider all three aspects. We tried to look at this comprehensively, but the ratings were too high no matter what. So due to ceiling effects, nothing came out. But we'll take it. It's not a bad research issue to have that the results are consistently too good to analyze any nuance. So instead of just getting numerical scale ratings, we got parents' actual voices, and some examples are that this was life changing, lifted a weight off their shoulders, that they were blown away, the benefits flowed onto a younger sibling, their child was a new guy, and commenting on how fast it works. So many positive changes in 2 weeks in such a short time frame. Another study aimed at addressing the gaps in this area, including asking parents before treatment rather than just at the end of the program, and asking them about the full range of treatment components separately rather than just asking them about the program as a whole at the end, or just one treatment components that might be presumed intrusive. So parents preferred components that were considered intrusive because they work way faster with less long drawn out problem behavior. And they actually want treatment that works, not just reduces inappropriate mealtime behavior, but that increases appropriate mealtime behavior that we want to see more of. Asking parents before treatment in a structured way is vital. Parents have a comprehensive outline of the possible treatments. They can take time to think about it without being in front of us, and they might feel more comfortable writing it than saying it. And this more formal and structured way opens up this conversation, especially because culture in Australia is different than mine. We really speak our minds. So I use this especially in balancing how fast to go with the progression, and giving parents more support if they're nervous, and figuring out specifically what their concerns are, not based on our own guesses or biases, because the concerns that parents have could be very different between each other. For example, cursing, vomiting, or weight loss. In the hospital, we had a kid who had severe intense problem behavior, and the mom was normally really chill about it. And one day after a meal, she was all like, "I'm so sorry," and was embarrassed and stuff. And we were like, "For what?" And she was just horrified that he had cursed and taken the Lord's name in vain. And this was a big no-no for their family. Another example, I used to think that the low ratings for our attention and interaction recommendations were because parents wanted to comfort their kids. But some parents were like, "No, we have a hard time not telling them off and reprimanding them in meals," as in they want to do that. So these results that we found were consistent with those that are found in the controlled hospital settings in feeding and in general behavior research in this area, even those that are obtained directly from the recipient, so the child themselves. So some of this might sound counterintuitive, but it could be because they like rules and consistency and knowing what to expect from us. Plus, they get to earn a ton of good stuff. And us as humans, we choose to do all kinds of things we don't like or feel like doing that could risk punishment. Like, I'm up here giving this talk right now that's on video. I'm sure there's parts where I'm stumbling and messing up my wording and putting my foot in my mouth. So instead of making our own judgments on the treatment by the name of it, what you call it, or what we think of it, we should focus on what the family says and what works for them and what is empirically supported. So even if we're collecting this type of data, it might not be reported in our papers because it's more subjective, and the publications focus on the objective data and numbers, and they have space limitations. So this was a scale development paper, getting the caregiver's input to make the survey questions specifically for feeding on what's meaningful and important to them, rather than using old scales that were designed for other purposes, or making up our own scales based on what us professionals might think is important to ask. So we use qualitative and quantitative methods using both. Thematic analysis is qualitative, and textual analysis is quantitative using a computer program. So this is a method that could be used to make custom surveys in other areas. that came out, and we made a caregiver-informed feeding-specific survey from this. The topics that were important were oral eating as a milestone, balancing satisfaction and expectations, that the benefits outweigh the negatives, that treatment should be more accessible, the importance of gradual progress, and then high levels of support and contact with the clinician. Another good thing that came out of this is some stuff that wasn't covered in previous surveys, like the benefits beyond eating and cultural beliefs. So all the ratings were high, above 6 out of 7. Another neat thing about this study is they got professionals that are in the kid's life to fill out the surveys too, not just the parents. So Dr. Laura Phipps has been doing some really cool research in this area on objective measures like indices of happiness. So a really neat thing they did, because they said, oh, dentists got to do intrusive stuff in kids' mouths. They got the dentist to rate the videos for the validity of their definitions. So they have also just published on using physiological measures like temperature and skin conductance or sweat during treatment. And starting to try to reliably define and validate these subjective concepts that exist in psychology, such as their concerns about reactions to feeding treatment. So Dr. Phipps and Peterson, who are on this publication, they were trained at the replication sites done by Dr. Kathleen Piazza. So she's the foremost expert in feeding, and she trained my professors at the hospital. So I contacted them and was super happy when they were willing to collaborate on the first review and discussion paper in this area. So if you have concerns about feeding therapy, this is the paper to read. We lined out future database directions to improve this area research and attached all 5 full text surveys that we made that can be adapted and used for other areas outside of feeding too. So feeding involves a lot of skill teaching, not just reducing refusal, which is what the social validity focus has unfortunately been on. There's lots of really neat studies that have already been done in this area and involve skill teaching. So lots of cool, novel, and creative ways have been developed specifically in feeding using tools we already have, like fading, which is making the gradual changes, like I showed y'all with Moreau with the spoon in the pouch. So there are so many options for individualizing treatment, like you can do practice with an empty spoon or an empty cup. And there's lots of variations on how you do exposure to food and drinks in these tasks. Other examples involve task analysis, so breaking the task down into small steps and then chaining the steps together from either the start, helping them from the start or the finish to increase independence, and specialized ways to teach chewing steps. Or to analyze skill versus refusal factors for different types of issues, like for spitting out or not swallowing. Like you could do texture assessments or use unique utensils and prompting supports like a nook brush to decrease response effort, meaning how much work does it take to help with skill deficits. So it's critical to balance the response effort, which is how much work it takes, both in the starting points and over time, because we talked about this earlier, food preferences change with exposure, and skills can become easier and more preferred once learned and practiced. Because feeding involves having to do things that may be hard or not preferred at first, cool creative stuff with behavioral economics can be done. Like, what are you willing to do for what prize? And it involves a lot of child choice and participation. So you could also figure out the child's motivation, their personal why for not eating, and then the child can choose between the functional reinforcers, like meaning escape and avoidance. We talked about this earlier. Interaction or items and activities. So depending on what the task is, so like what do they pick for Brussels sprouts versus pizza? And how many times do they have to practice Brussels sprouts before they start choosing to earn something rather than skipping out on the bite? And you can do this with a wide variety of mealtime targets and skills, not just variety. So here's some examples. This is Idale, the 13-year-old we talked about earlier. And again, myth proof, she didn't grow out of it. Treatment was simple, purely behavioral. She made repeated choices throughout, and she helped develop the plan. We were surprised because she wanted to do the hard stuff, so raw vegetables, and she didn't want to use any dips or anything. So it shows you the importance of individualizing what we do for each person. So she got different earnings for different levels of food as her preferences changed over time because of exposure and practice. So she got more tokens for harder foods. She didn't need any prompting. She did all of her exposure independently, and also no cognitive or talk therapy here, all behavioral. She got to 61 foods in less than 2 weeks, and a major goal of hers was Japanese food so she could travel there, and she did. We did her graduation meal at a Japanese restaurant. She ate heaps of new stuff. At 9 months follow-up, she reported relief from all the anxiety around food. She did amazing. I was super impressed with her. Similarly, here's Nico. He was 11. They had tried to get help since he was 18 months old, including a multidisciplinary team. He didn't use utensils or cup drink. He was dependent on laxatives, and others couldn't eat near him because he would gag. We did lots of preference assessments by food type and then made food groupings of high, medium, and low based on his preferences. And he got tokens for each food that went from 1 to 9 down the hierarchy. So like Idale, he did not need any prompting help, but he did need an exit criterion where there was a certain amount of bites he had to finish before leaving the table. He met all his goals in 2 weeks, 79 foods, eaten with his brother and at a restaurant. At over 2-year follow-up, the parents reported that the problem was definitely at an emphatic 5 out of 5, which was resolved, and that he had maintained all but one food. 8 years later, they said the program had solved all the difficulties he had. Variety had been easy to maintain. He doesn't need the protocol anymore, and everything generalized in a real short time frame, and there was no negatives reported. Here's Jubin. He was 9 years old. He had a history of having a NG tube in infancy. He ate no vegetables, fruit, or meat, and he didn't drink water. He was dependent on laxatives and formulas. He had years of treatment attempts, including medications, and an intensive multidisciplinary team research study at a hospital where he was admitted. He made repeated choices and chose which bite to take of 3 levels. For example, for a grape, he'd get 1 token. For cauliflower, he'd get 3. And we examined his preferences and choices before, during, and after treatment and in long-term follow-up. He met his goals in less than 2 weeks, and it maintained to over a year. This is a table of the social validity assessments we use. The first column has multiple time periods, and the next 2 columns list the multiple methods. So the 5 new surveys we've made, permanent product data, written and verbal data from the parents, qualitative and quantitative data, objective direct observation child measures, and like happiness and negative reactions, and child choice. So the last column shows the areas of social validity assessed within its comprehensive definition, plus culture, speed and treatment, and both positive and negative effects. Treatment involved individualized real feeding skill steps and repeated preference assessments to inform the starting points. So COMO's choices inform treatment progressions in 6 different skill domains, including medication and cup drinking. We matched how hard the task was based on his preferences and likes, and how hard the skill was to what he earned for each task. So we layered the quality, size, frequency, and timing of his earnings, his rewards, and incentives. This treatment evaluation format was really cool and could be adapted and applied by practitioners. This is one of our favorite treatment evaluation formats we've done. We'll show you in pictures instead of graphs because it's funner. So Como was 3. He had just gotten off a baby bottle. He only ate a few 3-month-old baby pouches and some soft foods like toast and baby cereal. He didn't feed himself or drink from a cup. So first, at the top, he picked the order of his favorite things to earn from left to right. Then in the middle, he picked the order of the targets to work on, like different textures, cup drinking, or medication. So what's easiest or most preferred for him to the hardest and least preferred things from left to right. Then we matched them up and flipped them in reverse so that the hardest thing earned his favorite and on down the line. So higher reinforcement for harder or less preferred tasks. He also chose where to start the treatment, and you can see at first he picked the easiest feeding target, the variations of foods he already ate. Even though he was dying for those Hot Wheels, it shows you the escape and avoidance piece. In the beginning is trumping actually earning things. And he was really cute and seriously checking out his choices. He was really good at this. So he made choices and we rearranged before every session. We put numbers on the plates of what the criteria were for how many bites of drinks he had to take. So he could choose which ones he did. And we increased this over time and by each category. So at the top, you can see he only got to do one task on one plate. Then next, he's got one task and three tasks on two different plates. And all the way on down the line till at the bottom, he was completing all four targets in all five categories. So he chose the order to do the sessions and when to start treatment in each of the five categories. And we've since got a little more technological with cute little flashcards instead of writing a number on a piece of paper. And after just 5 days, he had reached over 50 foods, including cup drinking water and medication. He got the all-time record of the 224 foods in just 3 weeks. And his sister did the program in the last week, and the family reached that dream of them all eating the same meal. Australia has the cutest animals in the world, even if they're trying to kill you, but also the happiest, and they eat their greens. So I had way too much fun looking up happiness memes, but there is a serious point to this besides quokka selfies and Australian actors like Thor. So we had to keep current and hip, so here's also Barbie and her quokka selfie. So quokkas have been taken over recently by baby Yoda Grogu because he likes to eat, drink, and be merry, even though he has been through a lot. So Bo's family are the ones who schooled us on this. They had a Grogu toasty maker that we got to use. And how neat is this? The parents actually met at a Star Wars convention. And then I ended up watching the show after, and I was like, okay, I totally get the obsession and all these Baby Yoda memes now. So this was the first time we took data on happiness. We had a lot of fun putting this data key into the program, and we're kind of cracking up about it. We made a few tweaks to the definition that was discussed in the paper by Dr. Phipps. For example, a child could throw a spoon and be happy about it. And we love this graph. It makes us super happy. Percentage of happiness is in gray on the vertical axis, and negative vocalizations are in black, so crying and complaining. And happiness actually increased with treatment. So Como only had negative vocalizations briefly for a couple sessions out of 100, and he had no negative reactions. Parents rated each part of the treatment before and after. So the lowest ratings they gave were for free and continuous toys and electronics, and for food rewards. So they wanted to only use healthy food and not junk food. And also for not interacting during problem behavior. So their preferences all increased to perfect ratings of 7 out of 7 after they experienced the treatment. They learned it, they did it themselves. So this is making a fully informed decision with first-hand experience of what the treatment is like. All these components they rated 7 out of 7. The parents were beyond amazing and provided so much vital information to collaborate on planning the treatment. And it's so important to ask them and tailor the intervention for each child and family rather than our own assumptions or opinions. As an example, Como's parents before the program said if we don't push him and guide him, we'll be doing him an injustice, which is very meaningful. They said they wanted to build solid foundations, do what was best for him and his life and his overall well-being and his future development. And they said The treatment was a must-have with rippling effects, and everything they could have asked for was not only met but exceeded on every level. They said it helped him to step outside of his comfort zone, to learn the value of food, and pushed him to achieve what he always thought he couldn't. And at discharge and 1 year follow-up, the scores were all also perfect, all 7 out of 7, the highest ratings. We've kept up with them at least yearly, and actually we just got an email from them with pictures of them in a cafe on New Year's Eve. And so that makes 4 years now since the program. And the email message said that they said a heartfelt thank you for us at the table to highlight how far they've come. You can imagine this was super special for us to read at 1 year follow-up. They said it improved his self-confidence and he wants to do everything himself. Words can't express the dramatic change in as little as 2 weeks, seeing him go from a handful of foods to over 200. He's more than willing to try new foods, happily sits at the table, and this has been the best thing for him and the entire family, the most life-changing experience of their lives. Most of all, it changed his life for the better and helped him more than we ever could have imagined. And when we asked about any negative side effects, they said no, not one, with 3 exclamation points. So even though we've been doing this for so long and have seen it work so many times, we still have these kind of feelings, especially looking at before and after progress videos. Sometimes you forget what it was like at the start, and we also still get blown away with things too, new, like the chopsticks. So Como met all his goals. He ate on the very first day of treatment and reached these full plates and learned all these skills in just weeks. And it's important to note the subjective info I'm presenting in this talk is just to supplement heaps of quantitative data that's like we were talking about before that we collect. And then his sister came. We had plates and cups everywhere. So for the first meal that we did when we put the whole family together, we were like, "Oh, what kind of music do y'all want to listen to?" And the dad's like, "Eminem's Lose Yourself." And so we're listening to that about the palms sweaty, and he's nervous. Mom's spaghetti. But the meal was so much fun to have everybody at the end at the table eating the same thing. And Como actually told his sister to take a bite, so he was in on it. Not many people do in-home programs, and we do it differently. So, in this publication, for practitioners, we also put lots of details normally not published on the logistics of the translation of this hospital program to home. And we also attach guidelines with individualization options that you can use away from home. So this is basically full child choice. Our version of the we provide, they decide. Don't push them. Set up for social meals and flexibility. And this is in contrast to their main protocol meals that the parents are feeding, just to make sure that they keep healthy and they don't lose all the gains they made. So there are lots of benefits to this child choice protocol, and a whole section of the paper discussing it. Because details on this in the whole admission and generalization typically aren't in the publications due to space constraints, and less data are taken on them. So that can lead to misconceptions for people not doing feeding programs. So these free access choice guidelines plus individualization options, they're for other caregivers like grandparents, nannies, school and childcare, social occasions, or when families aren't able to do a full protocol, like they're traveling or they're late. So Como, in his food graph with the 224 I showed y'all, Como ate a wide variety, near 100 foods in free choice meals. So that's all on his own choice, independent without the protocol. And it lets us see if he can go beyond the skills that we're at, like he would take bigger bites of things and stuff. So this is what we were talking about. Practice makes perfect. You like foods you eat. Exposure changes your preferences. Practice changes your preferences. So this gives such a balance to the parent versus child-directed meals. It allows more variety, so it prevents all those unbalanced proportions like too many carbs. So they get a small plate of a balanced variety, and it allows them at the end of the meal to self-regulate volume and intake, plus just gradually shifting from junk foods and huge portions of things like starch, rather than just cutting them all out. So I won't go through all of this, but just one example with schools, we've seen this really reduce staff stress and worry and increase the child's social participation. So we had a little girl, and the school's like, wow, she doesn't cry and run and hide anymore at snack time. So just giving some interaction recs can be life-changing for kids. Just stopping caregivers from nagging and arguing with them if they don't know how to feed a meal or follow through and do the protocol. So on independence with Moreau that I showed you earlier with the chopsticks, before treatment, we got a lot of valuable cultural social validity information and parents' perspective in the open-ended comments that we put in the publication. And this is before and after treatment and in follow-up. So before treatment, the parents preferred exposure techniques, but they rated electronic toys lower. He had never touched an iPad and barely watched TV, and they also, on efficiency, they wanted big results fast, and that's why they rated the exposure piece high. So they gave us so much good cultural information. Like they said, children use the chopsticks from a very early age, and in the daycare they have these Korean side dish plates, and typically they do large mixed bowls of large volume and less singular foods or snack foods that you finger feed, but she did want Moreau to do all that. So at discharge, their overall score was 6.8 out of 7. They had highly positive open-ended comments. They said, at first we were nervous and then ecstatic. They're forever grateful to have tackled the fundamental problem of eating. It's the greatest decision they ever made. Amazing and effective results beyond imagination. The chopsticks with an exclamation point, and that it was life-changing. And then at follow-up, they gave high ratings, all from 6 to 7, highly positive, open-ended comments. They said, we're so happy and still blown away. It's improved his fine motor, his behavior, his independence, his transitions. And this was the only treatment that showed true results, and the effects were immediate. And we did more follow-up with him the next year. I did heaps of meals outdoors, tons of parks and cafes that I need to pull the videos from. And did a whole plan for him to transition to school and eat independently. And he did it. So prevention, early referral, and progress monitoring are crucial. If treatment's attempted, the target needs to be consumption. So the person actually needs to be eating multiple foods from all 4 real food groups, including green ones, and age-appropriate independence in texture, and drinking water from an open cup within weeks or at most months. If they're not, they need to be referred on, and the younger the better. Most people get ineffective services for years, and it becomes much harder, and services are limited as they get older. So feeding should be the top priority, could be fixed quickly first because it can help with other areas like toilet and sleep, transitions, behavior. Treatment needs to be individualized and function-based, taking into account the patient's severity. Most cases I get here, I wouldn't even consider doing low-intensity treatment or until they got certain clearances done. They need to be properly cleared before you see them because medical risks are huge. For example, allergies or aspirations. However, if you do have a team, they may not know this area or be experts in it. Ultimately, we hope all this information helps to improve efforts to accurately disseminate this highly important, effective, acceptable, and valued treatment, increase access for families in need to improve their quality of life, and increase opportunities for training and education for practitioners. So we get asked for recommendations a lot. I'm not much on giving feeding recs because it's so risky, and I prefer to do individualized intensive treatment myself first before giving recs to parents to do alone or before we know what works. So plus almost all the families have already tried heaps of stuff that didn't work. But here are heaps of things that can be started on while someone's on a wait list or for super mild cases, even via telehealth remotely. So first, getting the medical and physical stuff taken care of and getting referrals and consultations rolling. I have heaps of resources on my website, and I'm mobile. I can go anywhere in home, doesn't matter where the family lives. And I can do virtual consults direct with the family or for professionals. So don't hesitate to contact me. I'm available and obviously obsessed with this stuff. Most times heaps can be done outside of meals before the program with the child, and that will really help. And targeting these areas can be way less risky than trying to give general recs for feeding. And also for caregivers, heaps can be done to prepare mentally before the program. Like I've mentioned acceptance and commitment therapy a few times, and there's free parenting courses in Australia, which is super cool. We have a detailed prep manual for parents with heaps of information on free resources and how to prepare. Plus, we have tons of free resources on our websites for parents, and they can access those before the program to learn about feeding and behavior. I've started having time to work with parents on some of this stuff before the program on telehealth to prep before the program, and it's been fantastic. So general feeding recs, these are some that are commonly given, but I just want to mention we really need to be careful with parents. They need help, and some of these recommendations can be risky and cause harm. So just, super common, told to eliminate grazing and, cut out preferred foods and drinks if they're underweight. Or, if they're underweight or they have aggression and self-injury, we gradually decrease this stuff in the feeding program and help parents so they're not dealing with a tantrum by themselves, and we set them up for success. So another example, blending or fading, this is commonly recommended and done, but if they only have a few foods or drinks messing with them, they could shut down and end up in the hospital. So there's some more technical articles and research that we didn't go over today that's freely available on my website. This is another talk that's the exact opposite of the take a bite that I'm always preaching. This is do not eat that. Don't take that bite, because with pica, they're eating and drinking deadly stuff that's not edible. And this is just as life-threatening as feeding. Ironically, you can have both. I've had several cases where we had to treat the feeding first before treating the pica. And this is such a cool, amazing talk, not only because the process is so unique and creative and fun. You have to create safe stuff that looks like what they're eating and drinking, but is tasteless and safe to practice with, so that you can teach them skills to use the stuff appropriately instead of mouthing and eating it. So we had baby pools in an apartment with fake sand and beach toys. It was really adorable. But also, like Moreau, we have video permission to show this in action, and we've even got Nick in a Aussie ugly Christmas rashy in here. And thanks a million for y'all's time and this opportunity to share what we're most passionate about. We really hope y'all enjoyed it and that it was helpful. And here's a QR code for a survey. We'd love to hear y'all's thoughts.